Hi everyone, my name is Samantha Rea and I'll be presenting today on adolescent telehealth use with considerations for health equity. And this is part of my practicum research project that's being conducted with UNC Pediatrics and Dr. Bianca Allison. So just for an overview, I'll be discussing background for the project, the study aims, methods, and results. I'll go through those results with considerations for health equity, and I'll discuss future directions. So for some background on the topic, many professional societies, including the American Academy of Pediatrics, recommend that adolescents have private and confidential conversations with their healthcare provider at every visit. And adolescents report that all healthcare should be confidential, and they identify confidentiality as one of the most important aspects of their healthcare. Yet many express concerns regarding privacy and worry that their confidential information may not be secure with the provider. So the American Academy of Pediatrics recommends discussing sensitive topics with adolescents without parents or caregivers in the room. But the National Survey of Family Growth reported that fewer than 40% of teenagers report spending time alone with a provider in the past year. So the transition to telehealth during the COVID-19 pandemic presents unique benefits and challenges for adolescents and their parents. And although the benefits of telehealth seem numerous, it's important to consider how this shift has affected adolescent privacy, alone time with providers, and their relationships with their doctors. So the study aims were to explore adolescent and parent perceptions of telehealth related to comfort, privacy, confidentiality, and therapeutic alliance. And this was a cross-sectional convergent mixed methods study. We recruited participants from September 2020 through January 2021. And we recruited them from 8 UNC primary care pediatrics clinics in the Triangle. And we administered online surveys through Qualtrics. And then for interested participants, we also conducted semi-structured qualitative interviews. So we had around 500 eligible adolescents and their parents, of whom 48 adolescents completed the survey and 13 were interviewed. And then 104 parents completed the survey, 19 of whom were interviewed. So these are the demographics from our sample. And as you can see here, the majority of our sample is white, non-Hispanic, cisgender female with really high levels of education and high SES. And so this obviously affects the external validity of our results, which will be discussed in a few slides. So in terms of comfort, our results showed that adolescents and parents are overall very comfortable with telehealth, and they report that it's convenient and easy to use. And 77% of adolescents reported that their video visit was very private, compared to 96% of adolescents reporting that their in-person visits were very private. And 31% of adolescents reported that they had alone time with their provider during their most recent video visit. So higher therapeutic alliance was associated with adolescent perceived privacy. And based on interviews with adolescents, autonomy and independence in accessing healthcare may be driving this relationship between privacy and therapeutic alliance. And in addition, higher therapeutic alliance was associated with previously established relationships with their healthcare provider. So keeping those results in mind, that adolescent telehealth visits were generally perceived as private, confidential, and supportive of therapeutic alliance for our sample. We always like to determine if an intervention is improving, reducing, or maintaining existing health disparities. And so especially given our sample of participants who are mostly white and higher SES, it's important to consider how telehealth could affect adolescents who are not represented in our study to ensure equitable health outcomes. So some of our interview results indicated that adolescents and parents were satisfied with the convenience of telehealth, and they reported that there were fewer barriers with time and cost associated with traveling to the clinic. They also reported that telehealth visits saved time in their day for other activities to prevent missing school or work, and families didn't have to depend on childcare to watch other siblings during their adolescence visit. So this item alone would likely reduce health disparities related strictly to convenience and access to care. And on the flip side, access to technology may not be equitable. And so telehealth requires enough bandwidth to accommodate video visits and other household members using devices simultaneously. And families may not have enough data on cell phone plans to support video visits. And furthermore, quality of microphones and cameras on devices could result in a loss of diagnostic accuracy. And so additionally, there's complexity with adding a medical interpreter to a video visit, especially for American Sign Language, as one study reported. And our study sample included English proficiency as an inclusion criteria, so we weren't able to assess how this affected families with limited English proficiency. And so these factors independently would likely widen existing health disparities. So privacy may disproportionately affect adolescents who are living with multiple household members. And so living in intergenerational households is more common for Asian, Hispanic, and Black families, which again may have been missed by our sample. And it demands consideration with regard to an adolescent's ability to find a private space in their home. Furthermore, some parents may not trust a provider to spend time alone with their adolescent for a variety of reasons, whether that's telehealth or in person. And telehealth may create challenges to privacy that are disproportionately shared by adolescents of color, those who don't have a private space in their homes, or those who don't have access to a private location that has the bandwidth to support a video visit. So our study found that therapeutic alliance was higher if the adolescent had an established relationship with a provider, or if they had higher perceived privacy during their recent video visit. And because of the reasons that were mentioned before about perceived privacy and intergenerational housing, privacy in the home may also affect therapeutic alliance. And it could also be affected by medical mistrust that Black adolescents and parents have with healthcare providers. It could contribute to individual provider bias related to social identities, or the ability of the healthcare provider to deliver culturally competent care. And so these obstacles with therapeutic alliance exist in person, but they may be exacerbated through a virtual platform. So for future directions, our study was fairly homogeneous, and it doesn't represent all adolescents in the triangle, which demands recruitment of a more diverse sample in future studies. And we learned that we could improve care delivery by ensuring that providers are assessing the adolescent's privacy during the visit, by verbally confirming confidentiality, and by utilizing technology features such as the Zoom chat or the use of headphones. And so we also need to collect data on the effectiveness of telehealth services in order to evaluate whether health disparities are being improved, worsened, or staying the same. And lastly, for adolescents who find that telehealth is really beneficial for themselves and their families, they should have the choice to continue accessing these services for appropriate visits. And both options should continue to be covered by insurance companies moving forward. This is my list of references. And that's all. Thank you so much for your time. If you have any questions or feedback, you can send it to the email listed on the screen. Thank you.